So I'm going to talk about kind of the landscape where we're at right now, so you know kind of where we're starting from here on out. And I just want everybody to know that everything that we've done is supported by the MHI grant from HRSA. And we give them acknowledgement for the resources. Now,
911, what's your emergency? Yeah, my wife got attacked by a warthog real bad, and I need someone to come up with an ambulance and pick her up. Okay, sir. Can you give me your address? Yeah, we're at 1825 Eucalyptus Drive. Okay, could you spell that for me, sir? I'm going to drag her on over to Oak Street, and you can pick her up there.
So I use that slide, one, because humor breaks the ice, and now we can all just relax and enjoy the rest of the day. But it teaches us an important principle. If you want an appropriate response to a crisis, you have to be able to provide appropriate and accurate information. And so today, our goal is to provide, hopefully, appropriate and accurate information so that those that are in positions to change and make differences, which is all of us in our own role, can go forward and bring about the change we want to see. So where are we? I've been co-director of the Iowa Statewide Perinatal Care Program for almost 20 years now. So I've reviewed every hospital in the state of Iowa during that time that has an OB program. During the years, we started to notice a trend that we had fewer and fewer hospitals to go to. And in 2018, we lost, I think it was 8 or 9 labor and delivery units in 1 year. Because of that, I sent out a survey to every CEO to all the hospitals in Iowa, asking them if they had an OB program. If they did, had they considered closing? If they didn't, did they close? And why did they close? And you can see here the counties of Iowa that had a labor and delivery program in 1999 compared to 2023. We've seen an immense expansion of obstetrical deserts in our state. And this is presenting a significant crisis. Not only do we have a crisis of access, but if anybody, most of you probably work in maternal health care like I do, I specialize in high-risk pregnancy. I can tell you I've never seen sicker patients than I'm seeing right now. So not only do we have an access problem, but we have an acuity problem, and those two don't go well together. In 2019, March, right before COVID shut the world down, I held a CEO conference in Des Moines for all the CEOs of the hospitals to talk about maternal health. And I did a survey, and one of the questions I asked, do you have concerns regarding the continued viability of your labor and delivery units? And this was to the CEOs of hospitals that had labor and delivery units. And 34% of them, or 34 of the 55 said yes. Well over 50% said they were concerned about the viability. We know that when labor and deliveries close, there is an association between that and bad outcomes. We see an increased neonatal mortality rate, increased premature birth rates, decreased outpatient prenatal care use and later entry to prenatal care, increased out-of-hospital births, increased labor inductions and cesarean birth rates, and increased maternal morbidity and mortality. Poor outcomes are always associated with higher cost. At the end of 2018, when we saw those closures, we saw the award, the request for application for the HRSA grant, 5 years, $10 million. And we thought we were in a great position to apply for that grant. Having traveled the state for many years and having the survey from the CEOs, I knew that the top problems in the state were workforce. Most of the hospitals actually closed because they couldn't find people to do obstetrics. They just couldn't find them. Education and quality of care concerns. They were worried about keeping their faculty and their nurses up to date on best care practices. Data was a problem in the state. Communication and coordination between agencies, and access to care. Because of that, we formulated the HRSA grant around those 5 areas. Workforce, what did we do? And I'm just giving you a 30,000 foot here. But we created the second in the nation rural track OBGYN residency at the University of Iowa. We now have, we take 2 a year. So this coming year, I think we started with 1. I think the first one graduates this year, or 24. And then we'll have 2 a year after that. So if your hospital needs OBs, now's the time to start wining and dining and getting to know these people. We created family medicine OB fellowships. Many hospitals in the state, general surgeons are doing the cesarean sections, and many of those general surgeons are over the age of 50. General surgery residencies no longer teach their residents how to do cesarean sections. It's not part of the curriculum. So the number one question I get asked by the general surgeons when I travel around the state is, who's gonna replace me when I'm done? So my answer is, I don't know. So we thought we would help family medicine docs become trained in performing cesarean sections and the complications that can occur. And we currently have 2, almost 3 fellowships in the state. And as you'll hear about later on, we will start the first class of certified nurse midwives in a training program at the University of Iowa. Education and quality of care. We became an AIM state and started to roll out the bundles. We also purchased a vehicle and outfitted it with all types of simulation equipment, from low fidelity to the highest tech you can find. And we actually travel to all the hospitals in the state and run simulations and teach them how to run simulations so that they don't rely on us. We're teaching them how to do them so that they can continue to do them afterwards. It's been an incredibly successful program. Data collection and harmonization. We're creating a standardized delivery and discharge summary form that will have all the data that we need. Because of my role in the perinatal program, I've also sat on the Maternal Mortality Review Committee for 20 years and reviewed every maternal death in the state over the last 2 decades. It's very difficult sometimes to tell a story when you're going through the charts. This will help do that. So if you're wanting a standardized form, contact us and we can help with that. Communication and coordination. I wanted to see one umbrella that looked over quality and safety, and so we created the Iowa Quality Care Collaborative, much like California's Quality Care Collaborative, and they have done just an amazing job of rolling out these AIM projects. And as Director Garcia pointed out, we have 100% participation in the last 2 AIM bundles. We're the only state in the nation that has 100% of hospitals involved. And access to care. 1, we're trying to create workforce so that hospitals don't have to close, and 2, we're trying to expand telemedicine so that people in rural areas can have access to specialty care. We have maternal fetal medicine, telemedicine, we have lactation support, and we have now maternal mental health. So that's what we've been doing the last 4 or 5 years during the COVID. Workforce, again, where will our doctors come from? We have to grow our own. It's very hard to recruit to Iowa. Iowa ranks 52nd, dead last. Puerto Rico and DC are ahead of us in terms of OB-GYNs per capita. ACOG predicts there'll be at least 9,000 provider shortage by 2030. That's only 7 years away, almost 6. And nationally, the number of family medicine residents that are practicing obstetrics upon graduation has decreased by greater than 50%. So again, we established a rural track residency, and I talked about that. I'm not going to spend a lot of time because we're on a time schedule here. But just know that we've got 2 a year coming out. And again, if you want to contact the program or contact these individuals, now's the time to do so because they're going to start graduating here. UI-affiliated family medicine practicing obstetrics in Iowa. As you can see, back in 1986, it was 68%. Last year, it was 7%. 7% of the graduating family medicine physicians said that they were going to practice obstetrics once they finished their residency. Over 50% of the hospitals in Iowa are run solely by family medicine physicians. There are no OBs. We have a real problem here. We have to start attracting family medicine docs to do obstetrics. The fellowship, again, I think a lot of family medicine docs are choosing not to do obstetrics for a multitude of reasons. Some, lifestyle. I mean, it's not easy. And this generation puts a lot more credit on lifestyle than I was. I wasn't smart enough to fight for that, I guess. And so lifestyle is important to these guys. Also, they see the acuity of the patients out there. And they're not surrounded by an infrastructure like I am. I have every specialty in the world at the drop of a hat. They don't have that. I mean, I give my hats off to these guys that practice such a high-risk profession as obstetrics out in the middle of these rural areas where they really don't have a whole lot of support system. It's frightening. And I think that scares a lot of them away. But hopefully, with the creation of these fellowships, we can reverse that course somewhat. And then the nurse midwife program, and I know Lastache is here and she's going to talk about this a little bit, so I'm not going to steal any of her thunder, but the opening class will begin now, I believe. Education and quality. Again, we became an AIM state. We've rolled out 2 bundles, the safe reduction of cesarean section and hemorrhage, and we're now just starting hypertensive crisis in pregnancy and the postpartum period. And the goal of this AIM is to provide evidence-based, high-quality care that we're all doing the same way. You know, one of my colleagues once said, there may be many ways of doing something, but when there is, pick one and get really good at it, right? We don't need 6 different Pitocin protocols in one labor and delivery unit. Just don't need it. Pick one and get good at it. And that's true of all things. We should pick evidence-based and standardize them to the best. And that's what the AIM bundles do. As you can see, the NTSV rate, as Director Garcia pointed out, we were able to substantially decrease, and we decreased it even more in the Medicaid population, which was very impressive. So it can be done. It can be done with education. Now, the thing you'll see is that you can see success during the time you're doing it, and then after you leave and you go something else, it creeps back up. That's what we've got to fight against. We got to keep it down where it's at and even continue to improve. And the hemorrhage bundles was rolled out, and we saw a significant reduction in transfusions and hemorrhage in the state. So it can be done. Best practices do work when you standardize them and everybody knows what they're going to do. The OB simulation team, as I pointed out, the thing that when I came up with the idea for the OB simulation, I wanted to do it in a mobile system. I didn't want to bring people to a sim center somewhere because the biggest problem with bad outcomes is typically a systems flaw. It's not dumb doctors or dumb nurses. Every once in a while we make mistakes. Sure, we're human. But most of the time it's a systems flaw. If I bring you to a sim center, I can't find your systems flaw. For example, one hospital in the state, when I was traveling around, they recently remodeled their OR, and it was on a different area, different floor even, than labor and delivery. And they bought brand new beds and everything. They made their L&D look great, and they ran a simulation of a cord prolapse, had to get to the OR. The bed didn't fit in the new elevator. They wouldn't have found that out if they'd run that sim in a sim center. They found out their system's flawed by doing it there. And I wanted to bring the sim center to you, which is what we've done with this mobile system. We also write our scenarios so they're level hospital specific. You're not gonna run a hemorrhage bundle at a level 1 hospital the same way I run one at the university hospital. Step 2 or 3 at your hospital, if you're a level 1 hospital, might be calling highway patrol to go to the other hospital and get blood and bring it here. I don't have to worry about that. I got all the blood I need. So we try to write them so that they fit the level of care that you are. And you can see there the points that we've come. The thing I didn't recognize was the hospitals that had closed their labor and delivery units were scared to death. I had a CEO call me up and said, Steve, I'm worried I'm gonna lose my docs in the ER because they're so afraid of a drive-by. And so they started calling us and asking if we could run simulations of vaginal deliveries and complications in the ER. So that's a whole new branch that we didn't think about early on, and it's become a big branch of the OB Sim group. Data, as I said, we're trying to consolidate and put everything into 1 or 2 forms that we can easily extract and tell a story and do data analysis on. The IMQCC, again, our goal is to reduce maternal morbidity and mortality, and that team has done a fantastic job of building, rolling out the AIM bundles, and putting together a lot of other committees. They've done a tremendous job, and I give them credit for it. I might be the PI of this, and I often say this. My role was to have the ideas, put my vision forth, and then surround myself with the people that I knew could carry it out, and then get the flip out of their way. I already determined they were experts, so why get in their way? And they've done a tremendous job. We've done all of this despite a 2.5-year world closure from a global pandemic. Our state has done far more than the other 9 states that got this grant, and I give them the credit for that. Again, telehealth. We wanted to expand MFM telehealth more than we've been able to because we had such a reduction in faculty ourselves, but we now have hired a couple of new, and so we hope to expand that. So that's where we're at. Those were the problems that I saw. That was the program we put together. Those are the accomplishments we've made so far, but we still have a ways to go, as this next slide points out. That's maternal mortality rate for the state of Iowa per year from 2015 to 2021. That's, people, is the ball. Don't take your eye off the ball. When you're talking about programs, solutions, that's the ball your eye's on. That's the number we have to reduce.